our office hours section. We're going to give it another 30 seconds or so as people trickle in, and then we will go ahead and get started. All right. Good morning and welcome to our office hours session as part of our Reentry Initiative Learning Collaborative series. This forum is intended for state and county correctional facilities, behavioral and public health agencies, reentry providers, managed care plans, and other key stakeholders with a significant role in the implementation of the CalAIM Justice Involved Reentry Initiative. While presenters are speaking, please, all attendees will remain muted. If you would like to speak, use the participants tab and click on the 3 dots next to your name and select ask to unmute. And then please also utilize the Q&A box for questions. This is our general office hours session that is to follow our Learning Collaborative session number 5, which was on enhanced care management for the JI population of focus. As you can see, we are approaching the end of our Learning Collaborative series for this year. The series will return some point next year. It may look a little bit different, but the goal is to keep these regular sessions of engagement going with all of our implementing partners. So today we are having a general office hours session. Our correctional facility office hours session was canceled for next week as it is obviously Thanksgiving holiday. So our next session will be session number 6 on the pharmacy policy, and that will be December 12th. And to follow that will be another general office hours session on the 19th. And with that, I will go ahead and pass it off to my colleagues, Michael Gillis and Jill Michelle.
Next slide, please. Thank you. So one of our questions that we received through the pre-release services and the pause / restart / reset, excuse me. What are the responsibilities for a county correctional facility if an individual exceeds the 90 days for the allowed pre-release services? DHCS policy allows for a pause and reset and restarts of the 90-day period to accommodate circumstances where individuals released. Each date may change or be extended unexpectedly. For additional information, please refer to our Learning Collaborative number 2, which will be provided in this PowerPoint and has been provided previously. If an individual uses their 90 days of eligibility, including any reset and restarts, the correctional facility must continue to meet all healthcare obligations, but may not bill Medi-Cal for services. For information, please see section 6.6 of the Policy and Operations Guide. Next slide, please. Pre-release services and the JI aid code. This is a question that DHCS received. If a correctional facility does not terminate the JI aid code on the day of release due to a delayed entering data, but Medi-Cal is reactivated, will the MCP be able to proceed with providing community-based services? The MCP enrollment begins with the JI aid code when the JI aid code is activated. The individual is put on a hold status during the period of incarceration. Upon the individual's release into the community, the MCP coverage is effective retroactively to the first day of the month. As such, if an individual's aid code is not changed to full coverage until a few days after the release, the MCP may still provide and get paid for such services as long as they are provided in the same month. Next slide, please. Managed care plan, MCP assignment. How will pre-release care managers, correctional facilities, and incarcerated individuals be notified of an individual's assignment into a managed care plan? The JI screening portal will display the individual's managed care plan assignment along with the enrollment status, either active, hold, or pending. Members who were auto-assigned will have an MCP available in the JI screening portal about 30 days after the JI code is activated. Special notes: for individuals that were already enrolled in a Medi-Cal or assigned an MCP upon incarceration, the individual's MCP enrollment will be put on their indefinite hold status until the MCP coverage is reactivated upon release. For individuals who were not enrolled in Medi-Cal nor assigned to an MCP prior to incarceration, the individual will be enrolled into an MCP upon release into an MCP upon activation of the JI aid code and placed on an indefinite hold status until reactivation upon release. Next slide, please. The managed care and enhanced care management. What should correctional facilities do if a ECM provider declines an assignment due to lack of capacity? Correctional facilities will assign in-reach pre-release care management and post-release ECM providers only for individuals whose MCP assignment is not yet known. When an MCP assignment is known, correctional facilities must use the MCP provider directory to identify a contract a JI ECM provider to serve as the pre-release care manager and or post-release ECM providers as acceptable. If the ECM provider declines assignment due to capacity, the correctional facility should reach out to the other JI ECM providers in the county. When the MCP assignment is known, the correctional facility should contact the MCP JI liaison for an MCP in their individual's county of release, who will make the assignment to an in-reach pre-release care manager post-release ECM provider. MCPs are responsible for ensuring an adequate JI ECM provider network and sufficiently providing capacity to meet the needs in their county of operation. Next slide, please. Care management and ECM. How many pre-release warm handoff meetings can the JI ECM provider bill for? And it's once per member, once per provider, and per episode. A warm handoff is a requirement in circumstances where the pre-release care management and the post-release ECM providers are different. The pre-release embedded care manager and the post-release ECM provider must bill for the warm handoff under care management bundle number 3, once per member, per provider, and per episode. In addition to the warm handoff, the pre-release care manager is expected to meet with the incarcerated individual to complete the health risk assessment, goals and objectives documents specifically in billing bundle number 1, and should conduct additional pre-release meetings with the individual prior to warm handoffs as medically necessary to meet the individual's needs specifically described in billing bundle number 2. Please note that the pre-release care manager may be an embedded provider or an in-reach community-based care manager who will continue to serve as the individual as their post-release JI ECM provider. Next slide, please. Care management and the ECM continued. In the event of an unexpected release, what is the expectation for the case management warm handoff? If an individual is released from a correctional facility unexpectedly, the pre-release care manager must ensure that the relevant medical records and reentry care plan are shared to the post-release ECM provider and the MCP within 1 business day of release, and schedule a warm handoff meeting with a post-release ECM provider and the individual within 1 week of release. Next slide, please. Behavioral health links. In the event of an unexpected release, what is the expectation of the behavioral health links? For those who have identified behavioral health links, a correctional facility must must complete behavioral health information sharing between correctional and county providers, supporting appointment scheduling with community-based providers, and complete any follow-up for a professional to professional clinical handoff or care linkage within 2 business days of release for unexpected and early releases. Upon unrelease to the community, it is the responsibility of the community health behavioral health agency to offer to schedule appointments on an ongoing basis as needed and within a clinically appropriate timeframe. Work with the MCP to ensure adequate transportation and to follow up with the individual, including by deploying a certified peer support specialist and working with the post-release ECM provider. Next slide, please. For individuals with specialty mental health services, SMHS, or drug Medi-Cal organization delivery system, DMC ODS, need, it is a professional to professional handoff always required. The professional to professional handoff element of the behavioral health link is always required, but handoffs do not require syncratic communication across the board. The determination about the level of syncratic communication needs for the warm handoff should be on a case-by-case basis. Take into consideration the complexity of an individual's treatment need and the condition. If the post-release behavioral health provider determines that a professional clinical handoff would be clinically appropriate, they should reach out to the pre-release care manager to schedule a handoff meeting. DHCS strongly recommends that the pre-release meeting be held with the member and the post-release behavioral health provider. And with that, I will turn it over to Jill Michelle to provide answers to the next set of questions. Thank you.
Thanks, Michael. Go ahead and go to the next slide. Let's see here. Sorry, I did not see this slide before. If a correctional facility has an NPI, is the facility considered a HIPAA-provided entity? And the answer to that is yes. If a correctional facility is enrolled in Medicaid, as a Medicaid provider, they are considered a covered entity with HIPAA. Next slides, please. Does DHCF have tools or models for correctional facilities to use to project expected Medi-Cal revenue for the 90-day pre-release services? Well, as you all, I'm sure, realize, this is a very new program. And while we do have providers that are submitting claims and claims are running through, we don't have any historic data which we can really help you with the projection models. As we get more and more of that data coming in, from the facility and from the counties, we'll begin to implement and share some of those anticipated numbers as we're learning about the different payment structures and how that's going to play out. Next slide, please. Okay, does DHCS plan to release a complete list of fee-for-service codes that are billable as part of the 90-day pre-release service? There is no consolidated list of CPT codes for the Justice-Involved Reentry Program, since the needs of the members are going to vary and they're very broad, so we do not have a list. The links that we can provide are in this slide, and they come from the CMS website, which lists the various Medi-Cal CPT codes that you can be using. And we encourage providers to maybe consult with a third-party biller or clearinghouse if they need to help to identify the appropriate codes for the JI pre-release services for Medi-Cal. We don't endorse any particular vendors, and as you're looking at this list, please make sure that it is current and double check that they are still in business. Next slide. Okay, are licensed clinical social workers providing pre-release services consider ORP providers? We have a master list where you can go on to the Medi-Cal website, and we can drop that in there for a list of various providers that are considered ORP providers. If they don't already have an active enrollment, then they need to apply and get for the NPI, and many providers may already be enrolled in this. As part of the demonstration, however, California did receive a waiver from CMS for enrollment for carceral providers who order, refer, and prescribe ORPs for pre-release services on an as-needed basis. A correctional facility seeking this waiver should add it as part of their readiness assessment, and they need to request this flexibility prior to taking it on. Otherwise, all ORP providers must individually enroll in Medi-Cal. Next slide, please. And with this note, I hand it off to Megan Shandell to start our live Q&A.
Thank you, Jill. At this time, we're going to open it up for some live Q&A. Maya Shashua from the Manat Health team will be helping facilitate that along with myself. Also joining us is, are two of our panelists from session number 5, Stephanie Lucio from Yuba County and Ron Klinger from Partnership Health. And they're just on to help support and be available for any questions that you may have directly for them, just to continue the conversation that we began during session number 5. So I'll turn it over to Maya to give us our first question.
Great. Thank you so much, and good morning, everyone. This is Maya Shasha with Manat Health. We will kick things off with a question that came through the Q&A feature regarding the Consolidated Appropriations Act of 2023. The question is asking if a county has not gone live with pre-release services by January 1st, 2024, if there are any additional requirements or if the county will be required to do anything to meet CAA expectations. I believe Brian is going to take a first pass at this.
Hi, this is Brian Jansen. I'm a policy advisor with the Director's Office at DHCS. And the answer to that is that we have been working with CMS regarding the CAA guidance. And right now, where we have landed is that all of the CAA requirements, the mandatory requirements, will be subsumed or rolled into the 1115 waiver Justice Involved Pre-Release Services Program. And that includes the timing elements of it. So counties do not need to implement any elements of the mandatory elements of the CAA on January 1st, 2024. They will be rolling those into their 1115 waiver pre-release services program according to the timing that they have selected. So everyone can relax about the January 1st date on that.
Thank you, Brian. And then I'll go to another question, which I believe is going to you, which is asking about the status of negotiations with CMS regarding the use of MAA funds to cover costs of screening for pre-release eligibility, if you're able to speak to that.
Yeah, I don't. We are hoping to have that program in place around the middle of next year so that it's available. I cannot guarantee that timing right now, and we are continuing to move through the process for approval with federal CMS on that. We'll provide updates when we have more information about what specifically we have gotten approved and what we have not, and what we're putting forward. I don't have any additional information on that, but I would expect in the coming months you'll see some more information on where we're at with those that MA process and availability. And again, we are moving towards attempting to have it available in the middle of next year.
Thank you, Brian. And we've got one more federal level question, which is just someone asking if it's possible for DHCS to speak to any anticipated impacts of the new presidential administration on California's 1115 waiver or future renewals, if you're able to speak to that.
Yeah, there are some things I can't say, and there are some things that I definitely can say. And the things that I can say are largely things that are irrespective of the presidential administration. And we've had a lot of questions. In some cases, our 1115 waiver programs have truly been pilot programs that were designed to be limited term and timed out after 5 or 6 years. The whole person care pilots is an example of this. They were there, they went away, they transitioned into something else, ECM and community sports. The justice involved pre-release services program is authorized under an 1115 waiver, but it's different in many ways that provide additional stability to the program going forward past the 5-year date. The first of those ways is that the option for states to apply for this type of waiver, it's not just the general 1115 waiver authority that's more subject to the whims of the federal administration for approval. It's actually enshrined in federal law that states have the option to apply for a pre-release services program, and it's now been structured out in the state Medicaid director letter, what's available. So that provides a lot of stability in the availability for states to use this option going forward, the fact that it is enshrined in federal law, which goes beyond just the regular administrative approval of 1115 waivers. In addition to that, it is also enshrined in state law in several different locations as a mandate and requirement. So I do not have any anticipation that this program will be going away. So I think we can all count on a fair amount of stability. Having said that, there is much that I cannot say about the future relative to the new federal administration. So thank you.
Thanks, Brian. All right. I see two questions in the chat asking about updates to various documents related to the initiative. Megan, I'm wondering if you or someone on the team may be able to provide any updates on how counties can obtain the readiness assessment for correctional facilities, if that will be posted online, and then any updates on the updated policy and operational guide.
Yes. So as far as the correctional facility readiness assessments go, those are not yet posted online. We're revamping that process. And so as we work to establish a new way of doing them, just side note, Jody and Michael Gillis and team, they're working really diligently on that, and it's moving along nicely, but it is taking some time. In the meantime, if you would like to request a template to fill out, you can email that request to us at CalAIM Justice Advisory Group at dhcs.ca.gov, and someone will return that template ready for you to fill out. But yes, that is being revamped. It will be an online process and hopefully be much smoother and user-friendly. So there's that. The policy and operations guide, as you all know, is undergoing some updates and some expansion of just guidance and clarification. And that is in its final stages, and we're hoping to release that real soon. Unfortunately, I don't have a targeted date or a timeline for that. We're just working as quickly as possible to get that out. And I think that was it as far as the two main documents. I do see another question about data reporting. I want to tack that on to my policy guide response. There is a new section on data sharing guidance that will be part of the new updated guide. So just stay tuned. That is coming and in the works. And I think we might even have a few more resources that we can drop into the chat as far as that goes too.
Wonderful, thank you. All right, just taking a look. I do see one question just asking about recordings for these office hour sessions and how folks can get a hold of them if they missed a session. Megan, would you mind just addressing that quickly? I know you all have a process.
So posting anything to our JI webpage is just short of an act of Congress these days. So we do have recordings available. And if you send a request to the CalAIM Justice Advisory Group email inbox, we can provide you a link to those. I believe they're on the DHCS YouTube, but we'll provide a link for the specific one that you're requesting if you just email us.
Great. There's a question that came through from Molly Brown, which is focused on the 90 days and JI aid code. I believe there's a written response coming, but might be good to just talk out This individual is asking whether there are a maximum number of days per year that someone can have their JI aid code active, and how that may apply to individuals that do not have a known release date or may stay longer than 90 days. I think the question just got answered, but I think it would be great to talk out. I don't know, Josh or others, if you may want to be on point, just so that everyone can hear.
Sure, I just put the response in the chat, but essentially when someone is been activated in the portal and they've got their initial day, 90-day set of services, if their release date does end up being extended, you would then do two things in the portal. You would pause the individual, and then depending on their set of circumstances, you would either reset them or restart them. So resetting essentially, gives them an additional 90 days of services. And then restart would really be once the reset has been, they've had their one reset, they would then pick up the remaining days of services that would be available to them. And also, just to add to that too, if they are incarcerated, later in the year, they're released, they've been discharged, they have a new incarceration period, again, they would be eligible for a new set of services.
Just clarifying, so if say their release date was extended, they've gotten 60 days of pre-release service up until that point because we didn't know their release date, and then we pause, we reset. When we do know their release date, they would get the remaining 30 days of pre-release service, or they would get 90 more days of pre-release service.
I'm going to phone a friend on this one related to the second part of your question. So Ashley or Sarah, could you help here?
Sure, of course. So Molly, are you talking about an adult or a youth individual?
An adult.
So basically the way it works for adults is that adults are permitted to have one reset per episode of incarceration. So in your example, if the individual was incarcerated for 60 days, right, you activated them with the assumption that they were going to release in 90 days. At day 60, something changes. So you had to go into the GI screening portal and pause them because their release date has been extended. If they have not had any prior resets, once it's within 90 days of that new release date, you would go ahead and reset them. That's their one reset. They get another full 90 days of services and then continue accordingly. Now, if this individual has already had that one reset and they've used up 60 days of that new reset period, then they would only be able to be restarted for the remaining days. Does that make sense?
That makes sense. Thank you for clarifying.
You're welcome, and good job, Josh.
Thanks so much. All right, I see a question that came in, which is on a topic I know the team has been discussing. It is asking for a little bit of clarification on licensure requirements for the pre-release care manager completing the health risk assessment and the reentry care plan, asking for a little bit of guidance about who can complete that. Does that need to be a licensed professional? Should it be overseen by a licensed professional, and which sorts of licensed professionals may be able to oversee this? So defer to the team on who wants to start us off.
I can start this off. This is a question we've been wrestling with a little bit and attempting to answer a few times. So the health risk assessment and the reentry care plan will include elements that need to be done by a licensed clinician, almost certainly. However, there will be other parts of those documents that do not, because of scope of practice requirements, do not need to be done by a licensed clinician. I think our answer right now, I know the policy guide says that the HRA and the reentry care plan need to be done by a licensed clinician. We've had specific questions on what types of licensed clinicians are okay to complete those. We've had separate questions about whether a care manager in general has to be a licensed clinician. So our current answers are that the HRA and the reentry care plan need to be done by a licensed clinician, and that a care manager does not need to be a licensed clinician, but that their work needs to be overseen, I believe, by a licensed clinician. So getting into the finer level of detail, I think and we're going to clarify this with our clinical experts who are not on the line right now, and we'll follow up. But I think the answer is that the HRA essentially needs to be overseen by a licensed clinician, signed off, and the reentry care plan essentially overseen and signed off by a licensed clinician. Parts of those plans that, because of what they are, need to be done by a licensed clinician because of the scope of practice requirements incorporated in the elements of those documents, then they would need to be done by that appropriate level of licensed clinician. Other elements of those documents can be completed if there is no specific scope of licensure requirement relative to the portion of that document. Those could be done by the care manager, who does not need to be a licensed clinician. Pretty complicated answer, and again, we'll follow up to confirm that, but that's, I think, the best I've got right now, unless any of our other folks on the DHCS team want to clarify that. Okay.
Thanks, Brian. All right, just taking a look. We just got a couple more questions in. Oh, there is a follow-up, Brian, to what you were talking about, which may be something to take back and continue to clarify with clinical leads. The person asking is just clarifying whether licensed professional is including individuals who may have a certification or license such as LCCP, LMFT, RN, LPT, not just a physician, physician assistant, or nurse practitioner. So defer to you if we want to take that back or answer.
Yes, admitting that I have no experience in clinical services. I've just been pretending I'm a doctor for the last 18 years for Medi-Cal. I think how we're sort of slipstreaming that answer is that there are scope of practice elements of what each of those clinical specialties are allowed to practice, and whatever portion of those documents needs to be completed. If that portion of the document has specific clinical requirements, then whatever level of clinician meets those requirements would be appropriate to complete that portion of the document. And yes, it does include other levels of clinical professionals other than physicians, including all of those you mentioned, according to the appropriateness of the activity and the scope of practice.
Thanks, Brian, and got a note that makes sense. So we can chalk that up as a win. Thank you for those questions. Really helpful, and I know that's been on a lot of folks' minds, so great to talk through. All right. We have a question on MCP auto assignment and enrollment during the pre-release period. The question is asking to clarify that this process for individuals who are enrolled in Medi-Cal during their period of incarceration, so those that were not previously enrolled in Medi-Cal prior to incarceration, confirming if that will take around 30 days and if there may be a more streamlined or rapid process moving forward.
I can go ahead and speak to this one a little bit. I am not our managed care subject matter experts, and I don't think we have them on this call today. But yes, the MCP auto assignment, we state in the policy that there's a 30-day window for that to occur. The hope is that it does not take 30 days to occur. In the event that the individual releases before they are enrolled in the MCP, the JIECM providers are also fee-for-service enrolled, and they will be able to continue post-release care in that period of time under fee-for-service. That being said, the managed care plans are also required to have network overlap, and so those ECM providers are going to be hopefully contracted with all the managed care plans in that county, so it doesn't matter which MCP the individual ends up being enrolled with, that provider would be part of that network. So that is the hope and the design. If there's anything more specific needed for that question, we can take that back to our managed care plan partners, our team here at DHCS, and they could help us flesh that out a little bit more.
Hey, Megan, this is Sarah over in eligibility. I would just add to that, we do have a work effort going into place. So that's really for the individuals that are not enrolled in managed care at the time of incarceration is where we're saying that 30-day window, just to allow that to be future forward. But we are also working on a work effort that'll go into place around July of this year that would implement same month enrollment. So we're hoping that that 30-day gap will be reduced even further as we get through this 2025 year and are able to implement some enhancements that'll help that process even further. So as that goes, we'll share additional information out.
Thank you, very helpful. All right, I know we have a couple policy questions left, but we did have one question come through from the previous webinar that is for our stakeholder panel, which was so wonderful during session 5. So wanted to lift that up to make sure there was a possibility of getting a response. And the question is a little bit specific, so I think it may be helpful, Stephanie and Yuba County team, to just give a couple sentences on an overview of your model for those who may have missed the session. But the question was asking if Yuba County is reimbursing Peachtree Health for care management for all individuals, including those that are not going to be a part of the reentry initiative. If there may be any MOU you've established or how you've sort of set up that relationship, if you're able to talk to that.
Sure. So our in-reach provider is an FQHC who's also a post-release EC provider. And so we have an active MOU with them that we achieved through an RFP process. Peachtree is only receiving reimbursements through the care bundles, not through any reimbursement from the county. And they're also able to bill post-release for that care coordination and warm handoffs.
Thank you so much, Stephanie. And others are always welcome to drop in some questions for Stephanie and for Ron and others in the Q&A, and we'll lift those up. All right. Just taking a look at the questions that we have. I think just sorting through all that have come through. We have one question on MOUs, which I think that we can address, which is just checking in on the template MOU between managed care plans and jails, and checking in on when DHCS plans to release that. And as a reminder, this is a requirement once the template MOU has been released for managed care plans and correctional facilities to enter into, but it's not a requirement prior to the release of that template. So this individual is just checking in on what the timing looks like for releasing that to stakeholders.
So as of right now, that's still the MOU between MCPs and correctional facilities is still under development, and we are anticipating a winter release date for that this winter, not next winter. But that is currently the targeted release date, and if that date changes, we'll communicate that out. But we're working as quickly as possible on that item.
And if I might just add that we are not encouraging correctional facilities and managed care plans to wait for that to start working on collaboration, particularly those who are closer rather than farther from launch. The policy guide indicates a lot of areas of interaction, and so it essentially provides a good framework for what the questions are that need to be asked between those two organizations for collaboration. And there's lots of texture that needs to be filled in with the specific details of who does what, when, and how. So we certainly, we don't want to kind of oversell what that MOU will provide. It'll probably largely be a framework of those questions, to help you figure out what you need to answer. And we probably already know what a lot of those questions are. So go ahead and start collaborating.
Hey, Brian, do you mind if I add a little bit to that answer?
Absolutely.
I just wanted to kind of clarify that. So the correctional facilities themselves are not defined as a HIPAA covered entity. However, the providers are. So that's in Yuba County how we've kind of been working with this thus far. I've been involved in the development process with the correctional facilities. Ultimately, it's communication between the plan and the provider that takes place that allows us to provide the upfront eligibility and assignment to ECM providers and whatnot. So that's how we've been working with it in the meantime.
Great, thank you. All right, so we've got a question from Rebecca asking if the process for individuals with SSDI granted Medi-Cal services who often require the client to go to a social services department office to get their out-of-county Medi-Cal transferred to the county where they'll be residing, if this is something that will affect the reentry initiative, and maybe just more broadly, if we could talk a little bit about circumstances where someone is being released into a different county than the one in which they are incarcerated.
Hi, Maya. I could take that. This is Sarah Linder from our eligibility team at DHCS. So I do want to give a little bit of background, as folks may not be familiar with the Supplemental Security Income, SSI, which is managed by our Social Security Administration. In California, when SSI determines someone is eligible, or when SSA determines someone is eligible for SSI benefits or supplemental security income, we automatically grant them Medi-Cal as part of their approval. And so all of their case management, including their address and their residence and everything that's related to their Medi-Cal, is actually administered by the Social Security Administration and not our county social services agencies. So that does make it a little difficult. And of course, SSA has their own rules for residency, for incarceration that impacts SSI, all of those things. And so while DHCS cannot really speak to what SSA's rules and requirements are, what we can say is for the purposes of Medi-Cal, if an individual is incarcerated in a county other than where they reside, their Medi-Cal case does not need to be changed to the county of incarceration in order to have them eligible for JI if the county in which they're incarcerated participates in the program and is already live. That being said, our guidance is that it's really a temporary stay, as the individual often intends to return to their county of residence upon release. So in those instances, we're not actually having the members change their county of responsibility or where their case is managed just to support or while incarcerated or support the JI program. So really, if they are on Medi-Cal, they have the appropriate eligibility that meets the program requirements and the county is live, then they can establish JI benefits and provide services and bill Medi-Cal regardless of where their primary Medi-Cal is established. If an individual intends to permanently reside in another county, then that would require the inter-county transfer process either done through or initiated at SSA for the SSI individuals or at the county social services department. I do know that SSA does take action to discontinue individuals on SSI once they've been incarcerated for a certain period of time. And I believe they also take into consideration whether or not their charges have been adjudicated and that type of thing. So they do have their own processes for that. If an individual is discontinued from SSI due to their incarceration, DHCS does pick them up and put them in a interim eligibility status while we transition their case to the county to have them reevaluated. Often with this population, when they do get released, they present themselves to SSA, and they're able to have their SSI reinstated and their Medi-Cal reinstated as SSI linked to Medi-Cal. In most circumstances, they'll do that because they're also eligible for that SSI income payment. And so there's really a benefit to them presenting themselves to SSA. But I would say that it wouldn't necessarily be triggered as a result of being incarcerated in another county. And then I did put in the chat as a response to a follow-up question, I think around the managed care eligibility enrollment. The managed care will be initiated, the enrollment will be initiated in the county of residence, again, where the individual intends to reside upon release from incarceration. So I know that was probably way more than you anticipated, but I wanted to kind of frame it so that everyone had a good understanding, but happy to answer any follow-up questions.
Sarah, this is Rebecca from Santa Clara County. Thank you for that answer. I think the part that we struggle with are those individuals that are intending to reside in Santa Clara County, but their SSDI or their Medi-Cal is in a different county, and they're not able to walk into the offices because they're incarcerated. And so we've tried to coordinate with the SSA or to try to figure out a solution for that, but we've never been able to get a solution. So I think the issue is that oftentimes clients will then remain in custody because of that. And so I was just wondering if there was going to be some type of mitigating actions that were going to help solve that issue.
Can you provide a little bit more context on why they would be remaining incarcerated because their Medi-Cal is not established?
Because the Medi-Cal, I don't know if it's changing, but before the Medi-Cal for behavioral health services had to be in the county that they were receiving the services. And so if the individual was going to receive services in Santa Clara County, behavioral health, either mental health or substance use, then their Medi-Cal had to be in Santa Clara County. And so in order for that to happen, then, we would try to initiate that transfer process. And that's where we were, we found challenges in trying to transfer those Medi-Cal benefits for those individuals that had that SSDI benefit.
Okay, so it would be in instances in which the release would be contingent on them receiving some sort of services that they're not able to access because the county is not appropriately aligned with where they're being required to obtain those services.
Correct.
And the intent is that even if they have court-ordered services, even after they complete those, they're still not going to reside in the other county?
Well, typically, if the individual says, no, I'm going to return to my county of origin, then usually those individuals get referred to that particular county. But it's the clients that say, for whatever reason, I'm going to be living in Santa Clara moving forward, that, we struggle with that transfer of Medi-Cal.
And does SSA state, in the past, I've heard that they've basically said the individual has to present themselves in person. Is that similar to what you're?
Mm-hmm.
Okay.
Yeah.
We can, I don't know how much we'll be able to do in this area because it does seem like this is more of a Social Security Administration process, but we do have some point of contacts at our regional office in San Francisco. So I can take an action item to take that back and see if there's any mechanism or ability to initiate that during incarceration.
Okay, thank you. Appreciate it.
No problem. Thanks for sharing all of that.
Thank you both. All right, just taking a look, we've got a couple other questions that have come in. I think, let's see. got one question that I just lost, so pulling it up momentarily. This is from Esther. And Sarah, I think this is sort of an add-on to some of the conversation that just took place, which is helpful. Esther is asking to clarify if an individual is incarcerated outside their county of residence and responsibility, and they stay in that county, will the inter-county transfer be different for those individuals? And that can be sometimes a very timely, time-consuming process to effectuate.
Yeah, unfortunately, transitioning county Medi-Cal from one county to the other is not as easy as it sounds. It is something that the department is constantly looking at, and my division is constantly working on improving that. But that being said, in the instance in which an individual is identifying that they intend to reside in another county, as part of the pre-release application processes and the ongoing communication between the local county correctional facilities and the social services departments. In those instances, that would need to be reported to either the receiving county, so the county in which they're moving, or the county in which their current Medi-Cal is established, so that that process can be initiated. It can take some time, especially because of our med system being as archaic as it is. I would say that they anticipate it's usually around a 30-day process, but it can take up to 45 days. It also impacts the managed care enrollment. And so we do ask or recommend that that be initiated as soon as possible, as soon as the individual identifies that they're going to be residing in another county. As part of our pre-release application processes, which are intended to be done at or as close to intake as possible, that's one of the items that we had flagged for correctional facilities and social services departments to validate and ensure that the counties on file are updated appropriately so that the managed care enrollment and all of the other coordination can be completed timely.
Thank you so much, Sarah. See a couple other questions. All right, there's a question on the mixed pre-release care management model, asking if correctional facilities can use embedded providers for a subset of the population and in-reach providers for the remainder of the population. So specifically, if it's possible to split the population rather than split billing bundles between a single individual. I think, Brian, you're hoping to get us started on that.
Yeah, and I don't have an answer to that specific question, but I wanted to just explain some background and let you know that we will follow up and get you an answer, which should be easy to do. The mixed care management model is envisioned primarily where you have a correctional facility that may want its embedded care managers to do certain activities that are appropriate for the embedded care manager to do mostly, and have an in-reach care manager based in the community do other activities that will be easier or more in line with the community-based care manager, setting up post-release appointments as an example, or working with housing services where the community-based care manager is much more familiar with the community environment. And in some cases, it may be that you're using that mixed model with the embedded care managers doing certain bundles and the community-based care manager doing other bundles for care management. There is one bundle, or at least one, bundle number 2 for general care management can be used concurrently by both care managers, not for the exact same activities, but for different activities that fit within the general description of that general care management bundle. So the question is about a different type of division of labor where a correctional facility may want to have specific clients being served by an embedded care manager and have a different subset of clients being served by an in-reach care manager. Like perhaps there is a community-based care manager that's has a lot of expertise in especially mental health or substance use disorder services. And maybe the correctional facility wants that community-based care manager to work specifically with those folks who have those specific needs and help that transition out to behavioral health services in the community, but the correctional facility feels like their embedded care managers can appropriately address the rest of the population who don't have those specific needs. That's the question we're going to take back and answer. I just wanted to explain the scenarios a little bit. Thank you.
Thank you, Brian. Right, I think we're coming up towards the end, and I know we've got a couple unanswered questions, but want to leave enough time to close out the session. So Megan, I think I may pass it back to you unless there's anything else you want to answer. I believe the team can take back and address some questions offline or at the next session. So I'll hand the mic to you.
Great, thank you, Maya. Thank you everyone for submitting questions. We really do love meeting with all of you guys and clarifying wherever we can. We do understand that this is a big program, not just for the state, but on the local level as well. And so we're here to answer any questions that you guys may have, and we really do appreciate your collaboration in these settings. Our next Learning Collaborative session and last one for this year will be held on Thursday, December 12th. And then you can please visit the Medi-Cal Learning Portal to register for and access the JI portal and Medi-Cal billing training sessions. And then as always, you can email us at CalAIM Justice Advisory Group at dhcs.ca.gov with any questions that you didn't ask today or that you still need clarification on. And with that, I think we will go ahead and end the call for today, and we look forward to seeing you guys next time.